The inflammation is so much more insidious than that, and it does affect ovarian function. We know that there are higher levels of pro-inflammatory cytokines within the follicular fluid surrounding the eggs in endometriosis, and the follicle function that of course contains the egg grows and matures under the influence of hormones in the first part of the menstrual cycle, and then is responsible for ovulation in the mid-cycle, is negatively affected by inflammation. So even egg maturation and the ovulatory process itself can be negatively affected, but then those inflammatory cytokines within the follicular fluid can actually damage.
Rhiannon Hardingham is a highly experienced degree-qualified naturopath and nutritionist and practitioner educator, specialising in all hormonal health issues, including perimenopause, endometriosis, PCOS, PMS and PMDD, male and female infertility, IVF support, pregnancy care, and postpartum and paediatric healthcare. Rhiannon expertly supports couples and individuals in their successful efforts to navigate their specific circumstances. Rhiannon is committed to the successful integration of natural and conventional medicine and believes ideal outcomes are achieved for patients when all of the healthcare practitioners are working together. She is regularly working alongside Melbourne's top fertility doctors, obstetricians, and gynecologists to achieve the best outcomes for her patients. As a testament, Rhiannon routinely is invited to present on topics of collaborative patient care to medical professionals and naturopaths alike. Rhiannon has also co-authored the book Create a Fertile Life and is a regular speaker on the practitioner education circuit. Hello and welcome to the Holistic Health and Hormones podcast. Today I'm super excited to have Rhiannon Hardingham with me, who is a highly respected and experienced degree-qualified naturopath and nutritionist and practitioner educator. She's specialising in all hormonal health issues, including perimenopause, endometriosis, PCOS, PMS, PMDD, male and female infertility, IVF support, pregnancy care and postpartum, and paediatric healthcare. Rhiannon expertly supports couples and individuals in their successful efforts to navigate their specific circumstances. She's committed to the successful integration of natural and conventional medicine and believes ideal outcomes are achieved for patients when all of their healthcare practitioners are working together. She's regularly working alongside Melbourne's top fertility doctors, obstetricians, and gynecologists to achieve the best possible outcomes for her patients. And as a testament, Rhiannon is routinely invited to present on topics of collaborative patient care to medical professionals and naturopaths. She has also co-authored the book Create a Fertile Life and is a regular speaker on practitioner educational circuits. Welcome to Rhiannon. Welcome to the podcast.
Thanks for having me, Ali. Lovely to be here.
Great. I personally had my own mentorship with Rhiannon. She is one of the best in the industry, and I would love for her to talk to us all, and for those especially who are going through endometriosis, adenomyosis, and really what the fertility truths out there are, because there is so much mixed information. There are people who haven't been diagnosed for years and years, and then when it comes to fertility, they have a shocking discovery that they've got something called adenomyosis or endo or both. So I'd love for you to share your wisdom, what for women listening who've been told painful periods are normal, or even some who don't have painful periods but then discover they have endo. What's the difference between having painful periods, between discomfort, and what is a red flag? Let's start with that.
I think that is a great place to start because there's a real tendency, of course, for women to both be gaslit by the system and to be gaslit by themselves around this idea that menstrual pain is normal at all. It might be common, but it's not normal. It's a phrase that I use often, of course. Menstrual pain is always a red flag. It's always an indicator that something is going on. About 30 to 50% of those with significant menstrual pain will be found to have endometriosis on further investigation. But even if it's not endo, of course, there's still a cause. We might call it functional dysmenorrhea. There may be other causes, but there are still factors to consider around things like inflammation and hormone balance and pain sensitivity for all sorts of different reasons, thyroid function. So, it's important to always take menstrual pain as a red flag.
How early should they be taking this seriously? Because I've now come across clients, and I'm sure you have, that it started in their teenage years. So when is it a red flag, and when should you be discussing it with your mom, going to the doctors and getting it checked out? How early should that be?
So certainly we used to say that endometriosis didn't really develop in teenage years, but now there's plenty of case reports, of course, of that lesions being found in teenage years. We know that there are genetic factors. So obviously if parents, especially mothers, but relatives to any degree, have an endometriosis history, then it's important to take it seriously in younger people. But ultimately, even if endometriosis lesions have not yet been established in teenage years, menstrual pain is a significant predisposing risk factor, unsurprisingly. And so now that I have, I've been working in this field for over 20 years, and I have patients, children who are going through menarche and dealing with their pubertal teenage challenges, and of course the daughters of my patients who I treated for endo, if they have menstrual pain, their mums bring them in really early, because at that point it's generally considered to be too early to go down a medical path and to undergo what are often invasive investigations. But functionally, there's quite a lot that we can do at that point, using the pain as that red flag guideline, so that we can then actually help to reduce the likelihood of adhesions and fibrosis or scarring from developing at all.
So can you just explain to those what is endo and what is adeno and what is the difference?
Yeah, so they're quite similar conditions, but endo is the growth of endometrial-like tissue outside of the uterus, commonly within the fallopian tubes, the ovaries, and the peritoneal cavity. Of course, we can also see bowel and bladder adherence, and then there's rare cases of it being found further afield, for example, in the lungs, etc. But predominantly we're talking about tissue that behaves more or less in the same way that the endometrium within the uterus does, but outside of the endometrium, usually in the pelvic cavity. Adenomyosis tends to occur later in life, so it's quite common over 40. But again, just like endo, we are seeing more and more of it in younger cohorts these days. But that is that very similar tissue, but growing into the walls of the endometrium. So of course, usually with menstrual lining that we see build up and shed each month, that's within the internal wall of the uterus and grows in and then is shed. But adenomyosis is when it infiltrates throughout the muscular wall of the uterus and causes lesions and adhesions within that wall, causing what we call a bulky uterus, which can be seen on ultrasound.
So why are so many women undiagnosed for years?
It is a really important question, one that, the government in Australia has been throwing a fair bit of money at in the last few years.
Yeah.
Not sure that I've seen any significant tangible benefits from that investment yet, but hopefully we will see it soon. I mean, the wait lists are still extraordinarily long for the public system in Australia. The diagnosis is invasive. We may speak about this later, but there are some less invasive investigations, such as a specific ultrasound that can show or indicate some potential of endo or prove some forms of endo. But ultimately, we're looking at surgery. We're looking at laparoscopic surgery, which out of pocket can cost you 10 to 20 grand. If you're waiting for a public health care investigation, Since COVID, it can take a couple of years. And of course, no one wants to jump into surgery unnecessarily. So the average time to diagnosis is about 7 to 10 years. But there's no doubt that those who have a better off socioeconomic position are far more likely to be diagnosed earlier. If you have private health insurance and a health literacy that leads you to follow these things up more quickly, you're far more likely to get a diagnosis within a reasonable window of time.
So once they've received a diagnosis, what has actually been happening hormonally in their body to their hormones, with the endo and the adenomyosis that's been happening?
So it's an interesting question. Of course, most people will know that there's a strong association between estrogen and endo and adeno. It's somebody, and the way that I practice, Ali, is somebody that as a practitioner over 20 years working almost exclusively only in this field has undertaken countless hormone tests on my patients. It is absolutely true that there is a strong tendency for those with endo to have higher estrogen levels. There are a couple of genetic predispositions that contribute to that, and we see those when we assess our patients' genetic profile. We see genetic predispositions that lead to a higher tendency to produce estrogen, as well as many that lead to compromised estrogen clearance. So, and beyond that, endometriosis itself actually has the capacity for what we call aromatase. Usually that's the job of the ovaries, to convert testosterone into estrogen to produce estrogen. But in endometriosis and adenomyosis, we have more tissue in the body that is estrogen, effectively producing estrogen. So there's literally more capacity to do it. So yes, mostly you will see a higher estrogen status. Not always, but mostly you will. Endo and adeno tissue is positively responsive to estrogen, meaning that estrogen encourages its growth and proliferation, and it is dampened by progesterone. And so if we see really high estrogen levels and insufficient progesterone levels, then we're far more likely to see this excess proliferation without that dampening effect of progesterone. In saying that, not everyone with endo has low progesterone. Again, it's just about testing, but that hormone imbalance is a significant contributor for many individuals.
So you're talking a bit about inflammation earlier. How does the inflammation, obviously it may have started, interfere with then now ovulation, egg quality in some of these women, obviously then implantation and the ability to conceive?
And it's a great question again, because we know that I think most people understand that with endo there may be actual structural challenges for their capacity to conceive, with lesions, scarring, etc. But the inflammation is so much more insidious than that, and it does affect ovarian function. We know that there are higher levels of pro-inflammatory cytokines within the follicular fluid surrounding the eggs in endometriosis, and the follicles themselves can be follicle function that of course contains the egg, grows and matures under the influence of hormones in the first part of the menstrual cycle, and then is responsible for ovulation in the mid-cycle, is negatively affected by inflammation. So even egg maturation and the ovulatory process itself can be negatively affected, but then those inflammatory cytokines within the follicular fluid can actually damage the eggs themselves. And from there, once fertilization has occurred, if it has occurred, of course, even the functionality of the fallopian tubes, fertilization usually occurs in the fallopian tubes, but inflammation can prevent the peristalsis, or the waves of the fallopian tubes that are responsible for sending the egg down into the uterus where implantation occurs. Inflammation can inhibit that, and so there's another barrier And then inflammation at the endometrium, very common in endo, also can inhibit implantation. So it's a very multifaceted negative impact on fertility, everything from egg quality through to ovulation, through to fertilization, through to actual implantation.
She mentioned the hormonal aspect. Also, I'm sure there are some gut aspects, and other sort of, aspects around so many things around endo. Let's talk a bit about gut and how that is also related to a lot of these hormones and what's happening, because people forget that it actually stems from a lot of the hormones that are produced in the gut.
Yeah, and is a very strong correlation between IBS type symptoms and endo presentation. And in the last 5 to 10 years, we've had a real explosion of research into the gut microbiome in all areas. And really interestingly, but unsurprisingly, there's a very strong correlation between gut dysbiosis, some particular bacterial overgrowth, some particular microbiome insufficiencies, some other imbalances that are commonly found in endo presentations. And that can contribute to everything from compromised hormone detoxification to disrupted hormone production, as well as most significantly heavily contributing to inflammation, systemic inflammation.
So it's a whole body. I mean, we always treat the whole body, but there is so much going on because it could have started, from the gut, and then now it's all, just all mucking up the hormones, and the more toxic we are. We live in such a toxic environment, right? Some people don't realize just the things they're doing every day has been contributing to that for years. We'll get to that in a bit, but let's talk about, you said some testing. So why is endo often missed in some of the testing? What sort of testing do people need to be looking at? And then sort of what are the next steps?
So at the moment, the gold standard diagnosis is a laparoscopy, of course. The ultrasound that I mentioned earlier will be able to identify if there's ovarian involvement, those chocolate cysts or the endometriomas that are found on the ovaries. And it can also see to a degree if there are some more severe endo presentations, grade 3 or grade 4. But beyond that, that ultrasound is not considered to be diagnostic. And that ultrasound itself is as invasive as an ultrasound gets. It's an intervaginal ultrasound, and it's a very thorough ultrasound, not your standard pelvic ultrasound. Then, of course, the surgery itself, there's some opportunity to use MRIs with quite good accuracy, but, I would say arguably I haven't seen wide adoption or availability of that clinically. It's certainly happening, but it's still expensive and not that widely available compared to those other assessments. And of course, it's also not therapeutic. Laparoscopy is both investigative, but then of course, if things are found, lesions are removed, there's potential benefit there. When we look at blood tests, there are some like the CA125 assessment, which is also an ovarian tumor marker. So it's emotionally often a challenging test to order, interpret, communicate. But beyond that, we're lucky that we have a lot of functional markers available to us, both in standard pathology as well as that genetic and gut testing, more functional pathology that can give us a lot of information, although none of them are diagnostic as such.
So when would someone look at then just managing their endo before looking at a laparoscopy, if that's the gold standard?
Yeah, I think if there's pain, if there are fertility challenges, if there's heavy menstrual bleeding, they're all reasons, of course, to look at the way that your health or complex factors that may not be affecting your health overtly, but in the long run may affect it, are relevant to you. And by this, of course, we're not victim blaming. I'm not talking about people need to stop eating McDonald's and they'll be better. Of course, a lot of the patients that we see come to us already having extraordinarily clean diets, if anything, restricting too heavily, trying to address their stress, maybe somehow all of that being rolled into something that's a bit more challenging because of this aim of perfectionism. There are factors that are really beyond the control of the individual without some nuanced understanding and management. But it is any of those factors are really, I think, a really strong indication that it's worth doing some further investigation from a health perspective, whether or not you're at the point where you would be willing to go down the medical investigative pathway.
So what do you say to people we've heard of people who've had multiple surgeries? Why is it that some are needing multiple surgeries? Have they had the surgery, perhaps not, change certain things? Their hormones are still producing the same, estrogen excess. What can women, with those sort of outcomes be improving so that they're not having to repeat? Hopefully it's just the one standard laparoscopy.
Yeah.
And from hopefully a good doctor, that they're not needing for the endo to come back, because there's many stories with people who have the endo coming back again and having repeated surgeries.
Yeah. First comment I'll say about this is about to massively blow up in Australia, because there's a Four Corners episode on. By the time this is released, it probably will have been on, about a particular Melbourne gynecologist who I've seen many patients who have seen him over the years, who has been accused of some pretty extreme unnecessary repeat interventions. That will all come to pass. But I think it's very important to select your surgeon wisely, which is a difficult thing just to throw out there. We certainly have our favourite surgeons, and we communicate with them, we work with them, we repeat refer to them. But beyond that, I think from a functional perspective, it's foolish to think that we can have a significant beneficial impact on reducing adhesions and scarring without surgery. Surgery is, when endo is established, surgery is incredibly useful. What we are able to do by utilizing our anti-inflammatory, our detoxification strategies, our antioxidant strategies, our immune modulation strategies after surgery is have a really significant benefit on reducing the likelihood of that reoccurrence. Surgery only, of course, removes established lesions, but it doesn't address the reason that the endo was there in the first place. So if we can look at some of those factors that cause the endo to establish and proliferate, whilst the surgery removes literal anatomical adhesions and scarring, that you just really are not going to regress with some turmeric. Together, it's quite a powerful effect. None of them minimal efforts, but over time we can see much better outcomes, I think, with good functional intervention after appropriate medical intervention.
So what would you say your top 3 foundational areas that you would look at addressing first when someone comes to you with endo or adeno?
Yeah, so definitely hormonal, of course, and that may be in considering certainly hormone levels themselves and how we can moderate those, but then looking at those individual detox pathways and assessing whether or not the gut is affecting estrogen detox, looking at whether or not there's adequate progesterone. From the gut microbiome, there's very few endo individuals who don't come back with an abnormal microbiome. As you know well, Ali, we do complex shotgun metagenomic stool testing. It's an expensive test, but the information that we get from it is profoundly useful. It's so rare to see an endo patient that doesn't come back with a complex microbiome assessment. And from there, thinking about that immune dysregulation and inflammation from a systemic perspective, which again is very, very gut related, but of course there are other factors to consider
Also
there.
liver as well. Can we mention a bit about liver detoxification and estrogen
Yes.
clearance relating to
Yeah.
that?
Yeah. So we have, of course, all hormones removed from the body via the liver, either then through the bowel or through the kidneys. And we look at phase 1 detoxification and then phase 2 detoxification. Phase 2 detoxification is quite complex. There are multiple pathways, chiefly glucuronidation, transsulfuration, and methylation, but they're all very, very different. And methylation, for example, most people probably don't really realize that just having a B12 deficiency significantly compromises your methylation, which then can significantly reduce your capacity to detoxify estrogen. So we will, of course, look at your standard LFT markers and get some information out of that, but then we may absolutely look at your individual genetic susceptibility to the hurdles that you may have with those different pathways. And I've never seen an endo sufferer without those SNPs that we call them in those detox pathways.
So genetic testing is so, it's so amazing, as well as the gut testing we're talking about, microbiome. People haven't had a recent microbiome test for their gut. It's so cool to see, and it gives you so much information, as well as Dutch testing. Love a good Dutch test, right? There's so much that a lot of these, I think a lot of the Western conventional doctors here, they are men, I'm sorry to say, that they don't understand a lot of this. And I had a client who came in and she basically has had painful periods since she was 15, 16. She's from rural Australia, and trying to get someone to, help her was just impossible, right? She was basically bedridden for 3 days out of the month. And yet those doctors were telling her it was all fine. It's all good. It's normal, right? When 3 days out of the month you were bedridden, and she never had any help until it was so bad she had to, get a uterus and things removed. It was, and then basically had it all taken out when she was about 39. Because she'd been suffering for over, 20 years, and no one addressed it in rural Australia.
Yeah, it's shocking. It's shocking. And that's the other thing about the socioeconomic accessibility is the geographical accessibility.
Yeah.
It's genuinely challenging.
Yeah. Let's talk about dietary changes. Like, we mentioned, don't want to get into too much, but what are some of the dietary changes clients who have been, sort of given Adeno and Endo sort of diagnoses, what could they be possibly looking at to do to perhaps even make some sort of difference to their hormones?
It's interesting because there's been very poor quality research around this to date. The largest study to date was released last year that showed about a 50% improvement. This is a self-reported survey, so certainly not gold standard scientific assessment, but you don't get gold standard scientific assessment when it comes to diet control, because you can't do a double-blind placebo-controlled study. People know what they're eating, and unless you lock them in a room for weeks and weeks and weeks, they also may eat things that they're not reporting. But as far as we can understand, this study showed us about a 50% improvement for those who cut out gluten, dairy, caffeine, and alcohol. And they were the key findings. What I would also say about it, though, is that I mentioned this earlier, but I'm really not a fan of excess dietary restriction. We, of course, working with predominantly women and those assigned female at birth in our practices, we see, of course, we're dealing with a lot of people who have had a history of either eating disorders or disordered eating, and often are still challenged with that, and do not like to clinically induce orthorexia if I can avoid it. So, my suggestion outside of a clinical setting is trial avoiding those things that you may feel negatively affect you, and give it a full cycle and assess the impact of that, but don't go on months or years long restrictive diets, especially where you cut out everything if you're not getting any benefit from it at all. In saying that, alcohol and sugar are not just, they don't just slow down estrogen detoxification, especially alcohol, of course, but they also induce aromatase. So they also increase estrogen production. So if you, ideally, sadly, the less alcohol, the better.
Yeah. Especially
And
in that
really the same goes for sugar.
And that
Yeah.
consumption window, I mean, for men and for women, I mean, it's best to just be minimal with all of that
Yeah.
when you are trying.
Yeah, exactly. Especially for fertility. Exactly.
Mm.
And then the other things that I would say from a positive perspective is a whole food, plant food. I don't like to say Mediterranean diet because any traditional whole food diet, will have a similar benefit, but we need fibers for the gut microbiome. If you had FODMAPs intolerances, which is of course are very common with the IBS/SIBO in Endo, then looking at how to address that rather than chronically avoiding legumes, onion, garlic, broccoli, those foods that are common triggers but are actually really good foods for your microbiome. So, of course, we do a lot of work addressing that bacterial imbalance or overgrowth to help our patients to be able to consume those foods and then benefit their microbiome diversity.
Yeah.
And then that helps with inflammation, oxidization, hormone detoxification. And the one last thing I'll say is soy. There's plenty of evidence that having good whole soy foods in your diet from a young age both reduces the incidence and severity of endometriosis. Big misunderstanding on the internet from the early 2000s. It still has some hangover that soy is bad for estrogen. Whole soy foods, incredibly beneficial for any estrogen condition, high or low, and very protective against the development of not just endo, but also PCOS, also breast cancer. Every woman and everyone born with ovaries benefits from consuming soy at any time in their life.
Even through perimenopause and menopause, right? Because of the imbalance of the hormones.
Exactly.
So people, have had this information around soy. So I'm like, look, if you can have good, healthy, organic soy, right, it's definitely better for you. Let's talk about some of your favorite supplements. I know it's still an individualized treatment, but what are some of your sort of top picks when it comes to people with endo and adenomyosis? What are some supplements that you've seen have the strongest evidence with managing some of these symptoms?
I think probably the straightforward go-tos without that real need for individualization, a really good quality fish oil.
Yes.
Very few people eating enough fish, and if they are, they're probably eating too much mercury and microplastics. Yeah. So unfortunately, most of us will benefit from a good quality, non-oxidized, low mercury, microplastic filtered fish oil. A good quality curcumin extract. And one that has the best evidence in the literature and clinically is really effective is N-acetylcysteine or NAC. Of course, we use a lot of it. Comes with a couple of caveats. It's not great for the gut, especially for people with gastritis. It can have negative effects on the microbiome. So you don't want to take it for long periods of time without having it individualized to you, without having it properly prescribed. And also there are a couple of those genetic detox pathway issues that I was mentioning before, related to glutathione that have reduced capacity to utilize N-acetylcysteine in the form that we convert it to, where it becomes an antioxidant, anti-inflammatory, that glutathione that I mentioned. So sometimes we need other forms. But there are two fairly large studies specifically on endometriomas that show a benefit both in pain and also a reduction in size of the cyst with the use of NAC, because we know that glutathione is an incredibly important detox and antioxidant molecule in the body.
So I just want to mention, obviously there's different stages of endo, right? Talk about sort of stage 1, 2, 3, 4. If it's sort of mild and there's not really coming up in some of the deep ultrasounds, how long would it typically take to see improvements? And could you avoid sort of the laparoscopy if it was very early stage endo?
Absolutely. Yeah.
Mm.
Early stage endo often won't need surgery and can be managed. I have, patients who I've been seeing, for close to 2 decades who have, either only had to have one surgery or have had, or we've managed it well from the start. But it is, it's such a varying degree. Like there are some of the most perfect patients who will still have severe endo, and others who are lucky. And there's such a variation.
Yeah. I mean, there's those who have the silent endo. I had a client who had silent endo for about 7 or 9 years, perhaps, but nothing except for a bit of an endo belly. There was no other symptoms, no pain, nothing, right? So I guess they could think themselves lucky, but then they didn't get diagnosed because it's not as obvious as all the obvious symptoms of endo.
Yeah. It's important to remember one of the key symptoms is just infertility, and one of the most severe cases I've ever seen. Her surgeon, when she was opened up for a laparoscopy, closed her up and backed away, and then sent her to a specialist endosurgeon who went in with a colorectal surgeon and a kidney surgeon at the same time. And then they were all back there again when she had her cesarean for her baby, for her delivery after that. Like all three surgeons seemed to be in the room for her surgery, for her Caesars. Very, very complex. Zero menstrual pain.
The same as one of
Zero
my clients.
menstrual
Yeah.
pain.
Same. She had 3 surgeons all operating at her
Yeah.
because she had silent endo. When they opened her up, they were
Yeah.
shocked at what they found.
Yeah.
So, yeah. How can women really then optimize their health, whether it's before IVF, if they've had that severe endo, even if it's for natural conception, right? What are these women really looking at doing to optimize their health hormones before the IVF if they've had this diagnosis? And also, how long is a wait period? Like, that's another thing we didn't cover, right? After surgery, what's the golden time to wait to either conceive naturally? Because it could be they looked at IVF, then they found there was endo, they've had the surgery, and now they could possibly look at natural conception now.
Yeah. And there are higher rates of natural conception after surgery. I think it's about 50% of those that will go in to surgery because of infertility will conceive afterwards. It might be 30%. Sorry, it's actually been quite a while since I've looked at that statistic, at least a year or two. But it is a significant portion. The wait time is not significant because it is laparoscopic. They are very, very minor adhesion. It's minimally invasive, tiny little cuts at the incision point. And they recover very easily. The other key consideration, the other key beneficial component to keep in mind is that they're not, with a laparoscopy, they're not going inside the uterus. It's outside the uterus. It's just in the peritoneal cavity, certainly looking at the ovaries, but it's not inside the uterus. It's not puncturing the uterus. The uterus itself, which obviously is the most important structure for the integrity of that pregnancy and where most of the pressure is not affected by a laparoscopy. They'll often undergo a hysteroscopy at the same time where they do look inside the uterus via the vagina, but there's still no incisions in the uterus. The uterus is largely left untouched. So it is not essential. It's not necessary to wait a long period of time unless there were really significant adhesions or interventions, and then it might be 2, maximum 3 months recovery. But it's actually not a general standard recommendation to wait for much longer than just one cycle.
Okay. So I guess what would you say to women who feel sort of hopeless after years of trying? What would be the first thing if they have had infertility, possibly unexplained? They may not, perhaps their GP or doctor just thought, go away, go try and come back. What would you say to women who feel sort of hopeless after years of maybe having an infertility diagnosis?
I mean, that, we see it all the time.
Yeah.
What I say to all of them is that you're in very good company. You just don't know it because people don't talk about it. But I sit here with people all day in your circumstance and you feel like you've never met anyone who's been through it. But that's very unlikely to be true. They just haven't spoken about it. But beyond that, it is really important for us, and I'm sure that you agree, not to give false hope. We're definitely not giving false hope, but we're also communicating very clearly that there are a lot of factors that conventional medicine doesn't consider, even though conventional science is very clear that it's relevant to endo prognosis and fertility outcomes. Conventional medicine at a clinical level just doesn't consider and include it. And so there are lots of things for us to consider that you haven't yet been investigated for or given the opportunity to optimize that can make a real difference. So let's spend some effort, money, unfortunately, and time thoroughly going through these things, and then we'll have a much better understanding of where you really sit, where the key emphasis should be, and of course, we will have the best opportunity to improve your chances, either for natural conception or alongside IVF and alongside assisted conception. That collaborative care is really important in endo and fertility.
So what's really possible then for women now who've got the endo and adenomyosis that they may not realize? I mean, everything's possible with conception. Could be that just may take them several cycles to really get their hormones to understand what was driving a lot of the estrogen excess. But what is really possible? I mean, obviously fertility is definitely possible for many. And what else can these women sort of do to start making those shifts?
Yeah, so of course we're also looking often just at functional outcomes for our non-fertility patients. So we're able to see improvements in heavy menstrual bleeding and menstrual pain, and then chronic pelvic pain that some of our patients have. So pain all through the month, all through the cycle, rather than just with menstruation, and really importantly, alter the disease progression. And beyond that, there are complications associated with endo that are, I think, pretty scary to read, to be honest, for people with endo, but a much greater risk of mental health presentations and PMDD and ADHD and autoimmune conditions, and unfortunately the list goes on, and it even gets a bit scarier. But the good news is that these are part of the systemic nature and imbalances of endo. So by doing things that address systemic inflammation, we're not just positively affecting your endo, we're positively affecting the way that your brain works. We're positively affecting your immune function, and therefore your risk of developing autoimmune conditions or cancers. We're positively influencing these more complex but related factors that we're just learning more and more about every year as we dive deeper into this from a research perspective. So there is more money now. There is more money for research.
Well, hopefully, yes. It should be starting well, I think, we should be sort of having this sort of, looked at in our 20s, not in our late 30s for a lot of people, because we're only starting to look at that when they're in that conception period. But really, it should be late teens, early 20s, and hopefully that happens, because obviously the more we go through the stress trauma, like you mentioned, be that chronic pain, imagine having it for 10, 15, 20 years. I mean, definitely affects our nervous system when we're constantly having that pain every month, systemic and hormonal dysregulation from all of the stress and trauma from just that alone can just be exacerbating the symptoms again and again.
Absolutely. And if we stop gaslighting ourselves that pain is normal in periods, then maybe we will start to see both medicine and individuals being more proactive about investigating these things earlier before there's a really established issue.
Amazing, Rhiannon. So just to summarize, really, what would you say as a closing remark around the whole endo, like for the sufferers out there for endo and adeno? What would your sort of summary be, or what would your, sort of takeaway be for them?
It's really tough. Like it's not, there's no way in which to sugarcoat it or minimize it. It's absolutely tough, and you wouldn't wish it on anyone, but it does affect a significant portion of our female population, at least 1 in 9, possibly higher. We don't really know. In our clinics, much higher, because it's about 50%, 30 to 50% of those attending fertility clinics in Australia who are female will have endo or adeno. But really, I think the take-home message is it is a complex chronic disease, but there is a lot of evidence and there are a lot of experienced practitioners out there that can help you. It's never a quick fix. Endo is not I'm going to treat you for 2 months and you're going to never suffer again. It's a lifelong chronic condition that requires a lifelong management. But if you are able to commit to that, those investigations and those treatments and work through it thoroughly and find a team, both conventional and functional, and often, of course, a naturopath nutritionist and an acupuncturist, often a psychotherapist or counsellor, and, of course, a good gynecologist and a great GP. Then,
a little team of
exactly,
people, because that's what it takes, a team.
It does. It really does. It definitely takes a medical village to support one endo patient properly. Again, it's important to recognise that it's a privileged position for people to be in, and it's not an option for everyone. But hopefully there is still, with this investment that we're seeing federally, we will see some improvement in accessibility across the board.
Amazing, Rhiannon. Thank you so much for sharing your experience, your insights into how people who are suffering, and there is so many people who are out there, that you get the right help and seek the right, information. And if your doctor is going to ignore you, please find more holistic naturopathic doctors such as yourself or myself who will really be able to help you in a more functional, holistic way.
Yeah, and refer you to a gynecologist who's willing to work with this.
All right, amazing, Rhiannon. Thank you so much for coming on today.
Such a pleasure, Ali. Always lovely to see you.
Thank you. Thank you for tuning in to the Holistic Health and Hormones podcast. Remember, endometriosis and adenomyosis are not life sentences. They are just signals of inflammation, immune activation, and a hormone ecosystem that needs recalibration. And when we address estrogen metabolism, liver clearance, and gut health, we don't just reduce symptoms, we optimize the environment for conception and implantation. And if this episode resonated with you, or you know someone who could benefit from it, please like and share, and know that your fertility journey just needs the right support. And if that's you, I invite you to book a free fertility focus call. Because your body is not broken, it may simply need a different approach. So until next time, honor your cycle, support your nervous system, and remember, pain is information. It's not your identity.